Hi everyone, this is Janet, and my deep dive has been about investigating the prescriptive practices of advanced practice nurses. Um, as you can see, I've written a prescription here that declares that advanced practice nurses should be able to contribute to the health and safety of the American people by practicing at the full scope of their education, which includes no restrictions on prescribing of medications, and the refills are unlimited. So the objectives of this presentation are to discuss the historical development of advanced practice nursing, particularly regarding prescribing and dispensing of medications, and then the culmination of the current political situation surrounding this topic. I've included within concepts related to implications for practice, as well as controversies and consequences, which have plagued the nursing profession throughout the years. I have embedded thought-provoking questions throughout the latter part of the presentation, and the purpose of those is to encourage discussion related to this topic. And then finally, contemplating who should monitor this practice if we should have it. Throughout the beginning of this presentation, I've included several old pictures of photographs of visiting nurses, and many of them have medicine bags with them, and I will discuss what's contained within those later on. And I apologize in advance because many of my slides are pretty busy because this is a very big topic. As I researched this topic, I began to realize that nurses have been engaging in activities which could be considered advanced practice nursing for many years, although not officially recognized as such. This photograph was taken in 1913 at the Public Health Nurse Quarterly. In 1893, it was a period of rapid industrialization and immigration to the northeastern United States. And new graduates Lillian Wald and Mary Brewster established a visiting nurse association which provided a variety of services mostly to immigrants. The Henry Street settlement was located in Manhattan, where they paid home visits to the immigrants, making referrals and dispensing physician-prescribed medications obtained from local pharmacists and household remedies, all of which they kept within their black bags. By 1900, their numbers grew to 12 nurses, and they made 26,600 visits per year. And questions began to arise whether they were practicing medicine. The question is, how do you define the practice of medicine in 1903? The article, a Practice Act, the State Nursing Registration Act, was enacted in 1903, and it included such vague terms that it brought up more questions than anything else. So it really wasn't clear whether the treatments that the nurses had been routinely administering based on their experience were included in the new bill. So these nurses frequently used mustard plasters and turpentine stoops, although I'm not sure what turpentine stoops were for, glycerin and honey for a sore throat, and aspirin evidently was a new drug at the time that was used frequently by a lot of people. Also the narcotic laudanum. In 1906, the Food and Drug Act was implemented, requiring disclosure of certain ingredients on medication labels. Lillian Wald's solution to this problem was to form an oversight committee of physicians who wrote standing orders for the nurses to follow. And And it sounds like uh, these the Food and Drug Administration Act, that it did not really change their practice a whole lot from what they were already doing. That's just a list of the medications on the Food and Drug Act. I couldn't find a picture of Mary Brewster. So the woman in the pictures here with Lillian Wald, her name is Jane Addams. So I was curious about her, so I looked her up, and evidently she has been attributed with a lot of social change. She was like the first social worker, and she was a major suffragette. She, along with Lillian Wald, established the settlement homes for the immigrants. And Jane Addams went on to be the first woman to be awarded the Nobel Prize in 1931. So, like I said, in 1900, there were 12 of the Henry Street settlement nurses. And then by 1923, they grew to a service that was seeing over 50,000 patients. By 1926, they were seeing over 300,000 patients. Across the country, and really essentially across the globe, it is apparent that visiting nurses were helping people obtain health care that couldn't otherwise. The middle photograph shows visiting nurses on bikes in Australia, and the far right one is illustrating the way in which the Frontier Nursing Service traveled to reach some of the most poverty-stricken people in the United States. It sounds like, to me, like the Henry Street Service nurses were practicing to the full extent of their training. So in 1925, Mary Breckenridge, a certified nurse midwife, founded the Frontier Nursing Service. And the aim of the service was to demonstrate the way in which nurse midwives could improve the astoundingly high maternal and infant mortality rates in the Appalachians. In 1917, prior to the formation of the Frontier Nursing Service, a court ruled that Margaret Hatfield had not practiced medicine by providing anesthesia. She had orders from a supervising physician. The Frontier Nursing Service nurses routinely administered ether during childbirth, which was the impetus for the development of what was called the medical routines. And they developed those in order to comply with the law. Essentially, medical routines were standing orders. And I've listed here some of the items which are included in some of the Frontier nurses' medicine bags, and I'll get into that later. So these photographs depict some of the Frontier Nursing Service nurse midwives. In 1914, another regulation was enacted to limit the amount of over-the-counter morphine, heroin, and opium which could be dispensed. But again, this law did not restrict the use by nurses who have doctor's orders. I think that most physicians at the time were happy to have Frontier Nursing Service nurses providing care to these people who were extremely difficult to reach, and so they gladly wrote medical routines. I wrote out one of the quotes from a 1928 edition of the medical routines, which I thought was really kind of interesting, where it talks about how much morphine to give for shock and the dosages, and depending on the weight and chest conditions and stuff like that. Anyway, it was very interesting. Apparently, these nurses were expected to assess, diagnose, and use their experience and judgment as to which drugs, dosages, and treatments to administer, So my question is, were these nurses engaging in prescriptive practices and advanced practice nursing? So throughout the mid 20th century, there were many nurses who continued to work independently while others began to work in hospitals. And in the hospitals, the boundaries between the medical profession and the nursing profession were clear, but there remained questions regarding the independently practicing nurses. Over the years, the political climate fluctuated while nursing continued to provide the desperately needed services to the underserved. Many nurses continued to engage in what could be considered advanced practice roles. So in 1955, in an effort to define the nursing profession, the American Nurses Association created a definition of nursing which would constrain the practice of nursing for the next several decades. The ANA's definition emphasized that nurses were not to engage in the act of diagnosing or prescribing, which effectively restricted the care that the majority of these considerably independently practicing nurses could provide. As Keeling points out, this may have been the starting point of the ever-continuing interprofessional conflicts over the diagnosing and prescribing practices of advanced practice nurses that we see today. So clearly, these nurses were engaging in advanced practice roles amid fluctuating political climates. But they almost always did this to fill a gap in the healthcare needs of families that didn't have adequate access to care. At the University of Colorado in 1965, a nursing instructor and a physician got together after recognizing a growing need to legitimize the practices of the nurses who were engaging in advanced practice by providing formal education, a program of formal education. And they did this not without a tremendous amount of backlash from both the nursing and the medical professions. Loretta Ford and Dr. Henry Silver formed the first nurse practitioner program, and the first class graduated in 1970. So rural practitioners welcomed the new nurse practitioner role, while many of the physician groups seemed to feel threatened by it. In the 1970s, a committee was formed to study the new nursing roles, and even then, they concluded that nurse practitioners could play a vital role in providing healthcare access to many Americans. And I couldn't find the exact date, but during that time period, at the urging of the committee, the ANA put out an addendum to their previous definition, which clearly states that nurse practitioners could diagnose and prescribe under special conditions, and those special conditions were yet to be defined. In 1974, the Council of Primary Care Nurse Practitioners was formed, and in 1985, the Academy of Nurse Practitioners was established. So I wanted to focus now more on the prescriptive authority as it occurred in Colorado over time. So in 1965, as I discussed earlier, the first nurse practitioner program was formed at the University of Colorado. In 1980, nurse practitioners gained independent practice but not prescriptive authority. In 1995, we obtained prescriptive authority but under what was called a dependent model, which meant that an 1,800-hour preceptorship was required, and then prescriptive authority was limited to 3 areas, including chronic and stable conditions, acute and self-limiting conditions, and palliative and end-of-life care. In 2009, legislation was passed which created a framework for the attainment of full independent prescriptive authority but it added another 1,800 hours of mentorship for a total of 3,600 hours. Evidently, this agreement was thought to have been a compromise between physician groups and not based on any kind of scientific evidence. In 2015, a bill was passed which reduced the number of mentorship hours to 1,000, and it allows nurse practitioners to obtain provisional full prescriptive authority upon graduation. Prescriptive authority includes unrestricted prescribing of drugs and Schedule 2 through 5 controlled substances with an articulated plan within 3 years. All of those steps culminate in full prescriptive authority. So this map is showing the states which allow nurse practitioners to obtain independent prescriptive authority. As you can see, Colorado is one of those states. Across the nation, even in the states which have implemented this, there exists a variety of pathways in which to reach it. Part of the reason that Colorado passed this legislation was that many of our nurse practitioner graduates were being recruited out of state because of the less restrictive practice laws. So I apologize, the next few slides are kind of busy, but I'll attempt to get through them quickly. I felt that it was important for you to understand the specific requirements in Colorado for obtaining prescriptive authority. So the provisional prescriptive license is abbreviated RxNP, and I want to go through a list of the steps to obtain an RxNP. The steps include the application and fee, a graduate degree, and a certificate showing your role in population focus, the satisfactory completion of the 3 state board required courses, pathophysiology, pharmacology, and physical assessment, professional liability insurance, verification of inclusion on the advanced practice registry, at least 3 years of clinical work experience as a professional or an advanced practice nurse, attestation that your mentor meets certain requirements, and an active RN and an APRN license in good standing. And then once you have your RxNP, you can prescribe medications including Schedule 2 through 5 controlled substances to patients within your role and population focus. And then, if you're not overwhelmed yet, so within 3 years after obtaining your RxNP, you must complete your 1,000 hour mentorship and develop an articulated plan. And if you don't get these done within 3 years, then your RxNP will expire. So here I've listed some very helpful documents which I found on the DORA website, where you can find the RxNP and RxN applications with a checklist, and on the DORA site they have an articulated plan toolkit which has some very helpful documents, which it also includes, and I'm interested in this one especially, the articulated plan toolkit template. And I think I already mentioned these last two. There's the link to get full prescriptive authority. The list of items, I think I mentioned the first two there. Anyway, the cost is a non-refundable application fee of $150, and your application expires after 1 year. So what's meant by an original RxN? And that means that, as opposed to the endorsement, the RxN by endorsement, the endorsement is for for APNs who have already been practicing as NPs, for them to get, it's a framework for them to get prescriptive authority. So the requirements for obtaining your full prescriptive authority include that you've completed your mentorship program with an authorized mentor, which means that they hold an unencumbered license to practice in Colorado. They can be either an MD or an APRN, are actively practicing in Colorado, and they have training, education, and experience which corresponds to your role in population, and they have full prescriptive authority. The articulated plan is a significant component for obtaining your RXN, and its purpose is to document how you are going to maintain collaboration with physicians and other professionals, and it is an agreement between you and the state of Colorado that says that you will adhere to the generally accepted standards for safe prescribing in the Practice Act. And I will go into each one of the items on that later, and most likely I won't cover them all completely, and so you'll definitely have to go to the website to check them out. And if you missed that part, you'll have to go to the website to check those out. I felt that these were just a few extra important facts that you need to know about the articulated plan. You don't need to submit your articulated plan when you apply for your RXNP. You just sign an attestation saying that you have done it. Then you retain your plan, update it annually, and it is subject to review at any time. Then you submit it at the end of your mentorship program, and it has to be signed by you and your mentor. After your RXN is granted, only you are responsible for updating your plan annually, and only you will be signing it. No longer will you need a mentor signature. All RXNPs and RXNs must hold a valid DEA registration in order to prescribe controlled substances, and you have to adhere to all of the DEA's requirements. And I know I was very curious about what is involved in this articulated plan. And so this slide highlights the most important points, and I'll try to get through it quickly. I'm sure that you'll need to go back to the website and look at it in more detail later, and keep in mind that there is a template available to guide you through this. So the articulated plan is based on the 4 standards of safe prescribing, and each of the 4 categories requires specific documentation which demonstrates how you plan to adhere to those standards. The first category includes documenting how you will maintain collaboration, and that includes an accurate list of resources or contacts and a referral list for clients. The second category is where you will provide a written plan for self-evaluation, and you must include how frequently you're going to do this. This category also includes peer review, practice setting utilization reviews, chart audits by you or others, and prescription audits, which can include the Colorado Prescription Drug Monitoring Program, pharmacy and other committees, and critical incident reviews. The third category is where you document your plan for using decision support tools, such as electronic prescribing databases, clinical guidelines, evidence-based prescribing guides, pharmaceutical reference guides, and professional journals. Your CE documentation must be maintained for 5 years and include the dates and titles of the programs you participate in, along with all of the names of the instructors, presenters, or authors. So, I don't know about you, I'm experiencing a little bit of information overload. So this slide, I'm just going to mention that on the Colorado State Board of Nursing, there are all the guidelines that you need for prescribing and/or dispensing opioids. Let's see. So as we discussed in class, yes, we do need a national provider identifier number in order to engage in any kind of electronic transmission of protected healthcare information. An NPI number is a 10-digit number, and I have the link listed here where you can obtain one. You also do need a DEA number to prescribe Schedule 2 through 5 controlled substances, and this application can be found at the website below. The application fee, if I'm reading this right, is $731 and is good for 3 years. And according to the DEA guidelines, APRNs can dispense and administer samples of medications also. There's the link. So, to summarize all of this, it's evident to me from the history that nurses have been engaging in what could be considered advanced nursing practices, including assessing, diagnosing, prescribing, and treating since before the 1800s, and have also faced multiple political obstacles over the years. Physicians' organizations have been attempting to impede the advanced practice activities of nurses for many years, and even the nursing profession itself has, at times, seemed confused regarding the creation of the APN roles. Regardless of the political climate, nurses have found ways to surmount the many challenges they faced throughout the years and continued to deliver care to the patients who needed them. In some ways, one could consider the hoops that we have to jump through as consequences of obtaining prescriptive authority by having to compromise with physician groups in order to get there at all. And that is also, I guess, a controversy. Even though the mentorship hours have been reduced, I'm confident that the articulated plan is going to require many hours of preparation and engagement. So my questions are, what are your thoughts on the articulated plan? What is your understanding of the number of CEs required? And do you think that that information is contained within the articulated plan? So what about the implications for our practice? From what I've gathered from all of my research, it appears as if physicians are under the impression that APNs do not want to engage in collaborative practice, which is not true. Some physicians' organizations who are resisting the removal of barriers to APN's practice, they're neglecting to realize the benefits of that action and are also refusing to recognize the problems inherent in keeping them in place. And those would be the increase in administrative burdens, the reduction in time available for both the physician and the APN to see patients, which causes an inherent decrease in patient satisfaction. And then the increased cost of the barriers may cancel out the benefits of hiring an APN entirely. Another implication for our practice is that we all need to be vigilant against engaging in any activities which could undermine all of the progress which we have made over the years. And Burhouse exclaims that APNs have reached a tipping point as a profession. I believe that what she means is that we need to take advantage of the current political climate. So Gladwell defines a tipping point as that magic moment when an idea, trend, or social behavior crosses a threshold, tips, and spreads like wildfire. I included this quote because I think it is profoundly suited to the political climate that we find ourselves in today. And here's another question for you. Do you feel that we are in any way placing our profession in a precarious position by pursuing prescriptive authority? So I ended up discussing prescriptive privileges rather than my question, which was regarding the level of prescriptive authority APRNs should have and who should monitor those privileges. So if barriers are removed, APRNs can practice the full scope of their education and provide the care which the role was designed to deliver. There are many pros to removing all of the barriers to APRN practice, and we're lucky to live in Colorado, where we're allowed to obtain full independent prescriptive privileges after all of the RxNP requirements have been met. So, my opinion is that barriers to APRN's prescriptive authority impede our ability to practice and attain the patient outcomes that we are capable of providing. But even as I resist the stipulation that I must have a mentor and jump through all the hoops to obtain my RxN, I admit that it is probably a good idea. So how many of you feel that you will be prepared to safely prescribe medications from the get-go? So the other question is, who should monitor those privileges? What do you think? Should we sit back and allow the very profession who has attempted to impede our progress for so many years to be in that position? And if not, who should do it? There are some people who have raised the question of whether having physicians regulating the prescribing practices of APRNs is wise or not. So I apologize for the length of this presentation, but I do hope that you found it to be informative. Thanks for watching, and the following slides contain my references.